Hello everyone, I am Ester and I am Senior Attending Physician at La Fe Hospital. I work in paediatric gastroenterology and we're going to talk about granulocyte and monocyte aspheresis for pediatric inflammatory bowel disease, the role it has in these cases, and we will discuss also some successful cases at our center. As you all know, pediatric inflammatory bowel disease is a chronic inflammatory process with flare-ups. It presents in several forms, such as Crohn's disease or ulcerative colitis, and it is important to highlight that the characteristics of the disease are different in children compared to adults. Crohn's disease is more predominant in children, they appear in more extensive forms. In general, its progression is to more complex phenotypes, and there are many extraintestinal manifestations. The general goals for treatment are to obviously achieve remission and be able to maintain it in the long term, improve children's quality of life, avoid complications, and minimize treatment-related adverse events, to preserve children's growth and sexual maturation. The inflammatory activity is associated with an increase in cells such as granulocytes and monocytes or macrophages that are activated in blood, but there is also an increase in their intestinal infiltration. There is therefore a therapeutic option, which would be to try to reduce the number of these cells in the tissues and blood via a technique called cytopheresis. It was reported a long time ago, but the first pediatric serial publications are from 2000 onwards. We currently have different pediatric studies that can provide us with data on the role of granulocytoapheresis in pediatric inflammatory bowel disease scenarios. This system is an extracorporeal system that requires the insertion of two blood access lines. One line is connected to the patient with the flow that reaches the column that cleanses the blood and is then reinfused to the patient. It can normally be performed via peripheral lines. It usually lasts 1 hour, and it's a technique that is quite well tolerated. This apheresis column is a column filled with cellulose acetate beads, which granulocytes, monocytes, as well as a few lymphocytes adhere to. Therefore, their removal from the blood causes them to also be removed from the tissues. However, not only are these cells removed, but also inflammatory cytokines are also withdrawn. For example, in this 2018 study, as this publication tells us, 7 patients with a diagnosis of inflammatory bowel disease were analyzed, 5 of whom had ulcerative colitis, and a group of control patients who underwent endoscopy for diagnostic reasons other than inflammatory IBD. These patients had received the first line of treatment, which was mesalazine, and were subject to 10 sessions of apheresis. The goal was to learn whether there was a decrease in the PUCAI, which is the index measuring ulcerative colitis activity. Other items were also assessed. For example, as you can see, there was a significant decrease in the PUCAI in children after treatment, as well as a significant decrease in the endoscopic index of the Mayo score. Control patients were seen to have a smaller amount of inflammatory cytokines, and, as seen in the graphs, these patients were seen to have, after treatment, a significant reduction in inflammatory cytokines. As I mentioned before, the pediatric studies are from 2000 onwards, more or less, the first to be published. This study came out in 2003 and is very interesting. It is a retrospective study on 12 patients with ulcerative colitis. These patients were subjected to 1 weekly session for 5 to 10 weeks, and of the 12 pediatric patients, the symptoms significantly improved in 8 cases after 2 weeks, achieving monthly clinical remission. The amount of corticosteroids or the corticosteroid dose could be reduced in 50% of the cases without reporting any adverse events. Moreover, remission was maintained over time in 4 of the cases for almost 1 year after treatment. We also have studies carried out in Spain. This is one that our center also collaborated on. It's a multi-center retrospective study on cases where patients with inflammatory bowel disease were subjected to apheresis as treatment. There were 9 patients, 5 of whom had ulcerative colitis and 4 had Crohn's disease. Those with ulcerative colitis were corticosteroid dependent. A central line was needed to administer treatment in these cases, or it was decided to administer via a central line at that point. They were subjected to 5 apheresis sessions of 60 minutes each, where the efficacy of the treatment was observed in the patients with ulcerative colitis. Because of the 5, 4 achieved remission. It was evidenced as a safe technique without any side effects and was fundamentally effective in ulcerative colitis cases. This study is very interesting as it is prospective, multicentric. It is the ADAPT study that intends to evaluate the efficacy of apheresis in patients with ulcerative colitis, who have also undergone the first phase of treatment. As shown in Table 1, these cases are children diagnosed with ulcerative colitis, but who were taking a first-line treatment, either mesalazine or low-dose corticosteroids, or some of them can be on treatment with an immunomodulator, but without any changes and in a stable way. They were all subjected to 5 apheresis sessions once a week, and in some cases, they could have been extended even more. The goal was to achieve remission via the PUCAI score, and of the 25 patients, 21 were analyzed. The other 4 were not included because, well, they had other previous complications. And in 12 weeks, a decrease in the PUCAI was observed. They entered with moderate activity of 35 to 64 and decreased to 22. 7 of the 21 patients required administration of corticosteroids or bolus of corticosteroids, but no severe adverse events were reported. In the table on the right, Table 6, it evaluates if there is a significant improvement in the PUCAI, moderate or mild, and a significant improvement in the PUCAI was observed in 25% to 45%. Therefore, apheresis really could be considered as a treatment option following first-line treatment failure. Do not leave it as a rescue therapy option at the end, but try it in patients on the not very aggressive treatment. Now we move on to the real clinical cases at our center. This is a case of a 7-year-old boy who was diagnosed with ulcerative colitis in 2007. He started treatment with oral and topical mesalazine, with a partial response. It required combination with corticosteroids, and the patient had a good response. But when we started to taper the dose, the patient relapsed. That is, he was considered corticosteroid dependent. In this case, the mesalazine dose was increased. Because he was taking a low dose at the start, he was not taking a very high dose, and prednisone was also increased. By decreasing the corticosteroid therapy, he had a new flare-up. Therefore, he was considered corticosteroid dependent, although he was going to start azathioprine therapy, which, as you know, requires time to reach optimal doses. Apheresis was combined as a bridge to the effect of azathioprine. It really went well. It was administered via peripheral lines, it was very well tolerated, and the corticosteroid therapy could be decreased until its discontinuation. The boy, who is now an adult, he moved to the adult department and is well. He is continuing azathioprine. He is stable. So, as indications, we could consider either the traditional indication for apheresis or what we have always had in mind is patients with mild, moderate ulcerative colitis, corticosteroid dependent or corticosteroid refractory. Dependence is the inability to discontinue corticosteroids within 3 months, or if there is a relapse 3 months after discontinuing them. And in the case of corticosteroid refractory patients, it is also a good choice, especially if we think there is a lack of response or an intolerance to biologics or immunomodulators, and also as a bridge, as it has been the case of our patient, to response to thiopurines until they are fully effective. The following case is that of a 5-year-old girl, diagnosed with ulcerative colitis at that point, with extensive and severe involvement, who started with a severe PUCAI, who required admission and intravenous corticosteroids. However, due to corticosteroid dependence, required combination with azathioprine. Therapy had to be discontinued, as she showed hypotoxicity to azathioprine. They tried to decrease the dose, change to marcaptopurine. They were unable to do so. Although she was stable of the pediatric inflammatory bowel disease, At that point, they decided to discontinue azathioprine and maintain it with oral mesalazine and budesonide enemas. However, the patient presented a new relapse with a follow-up colonoscopy that showed extensive pancreatitis, and they decided to start therapy with an anti-TNF, which was infliximab. She had a good initial response to the initial induction regimen, but she had a new relapse after the third dose. At that point, they decided to intensify infliximab therapy, decreasing the interdose interval, but the patient continued presenting symptoms. In this scenario, apheresis treatment was recommended. In this case, she was a girl who was in good general condition. She required a central line, which she received in the ICU. It was a temporary central line. And the truth is, it was a very intensive regimen. Normally, we perform apheresis once a week for 5 to 10 weeks. In this case, they performed 2 to 3 weekly sessions, slightly to try so that the line could hold on. The truth is it went very well. Adalimumab was subsequently started and the patient had good evolution. And this could possibly be another indication for apheresis treatment in patients with ulcerative colitis or even Crohn's disease, a combined therapy with a biologic, because this way we can try to avoid loss of response to biologic therapy, or providing it in a unified way, try to achieve better efficacy from the beginning. So to summarize all this, that is, apheresis is a non-pharmacological therapeutic option with which we can avoid those adverse events from medical treatments that we do not like, especially in children, and we must particularly keep it in mind for children in at-risk situations for immunomodulator or biologic therapy. It would be of particular interest in cases of mild to moderate ulcerative colitis, corticosteroid-dependent or corticosteroid refractory, and we also use it in combination therapy with biologics in specific situations. And that's everything I wanted to tell you up to now.